Derek, we are checking microphone. We are checking the microphone. Microphone check. 1, 2, 1, 2.
For June the 27th, I'm informed of no citizens needing to address the board, so with that, we will move on to our approval of the minutes. You should have those in your packet from May 23rd meeting. Is there any questions? If not, we entertain a motion to approve those. Motion to approve, second. Any discussion? All in favor, say aye. All opposed, same sign. That motion carries. Thank you. And with that, Jill, we will turn it over to you for the Master Facility Plan Construction Placemat update. Good morning.
Good morning.
David, how are you, sir?
Good morning, sir.
Okay, well, a lot of good things to say. I know the CFO work got completed. The rooftop insulation, or the rooftop units are installed. Things that are coming up for this month, the roofing is almost complete. And of course, we're still finishing out the interior of the building. So MEP, in-wall, drywall is going on right now. And we should have permanent power here this week. Still on track for December 4th completion date. Pretty simple today. No questions, move on to the PEC. The PEC, we turned over the lobby. The connecting roof's almost complete, or the connector roof is almost complete. The PEC exterior framing's ongoing. Roofing installation is nearing completion. The Jennings CFA water shutdown's complete, or it's complete, even though it doesn't say that on this. And we're still tracking towards end of July of next year, 2025.
All right.
No questions. Move over to the garage. This is an exciting one. I know everybody's probably seen the mounds of dirt piling up as the demolition has occurred, and the removal of soil as soil gets tested and gets hauled off to the appropriate landfill. Things people don't see is all the precast work is about 80% done. It's off-site, so it'll be brought on as soon as the piers and that kind of stuff are being installed currently this month. And we're set to open April of 2026.
A couple questions. We got a lot of rain the last few weeks, I guess, and that's probably done now as I just walked in from the parking garage. I needed to shower again. How did the sites do with all the rain and everything?
They did well, but it did slow us down a little bit. The good thing is, the jobs that are having site work, we have a lot of time to try to make that back up and change schedules on critical path.
Great.
Not always that way. Now, on the PEC, we've had a lot of water or a lot of rain for a while. We've eaten up the majority of our rain days on the PEC. But so far, we're still maintaining schedule.
Did the volume that we got affect any of our sites, anything like that we're concerned about?
Just the temporary parking lot.
Okay.
We've had some, issues with that.
Yeah. It was a lot of water.
Yeah.
Yeah.
I think we're done now.
I know. I kind of want a little bit of it back.
We may be begging for that water back.
Right.
I have a quick question.
Yes, sir.
More convenient. Because right now it's very hard for a handicap to park across the street from us.
Yeah, the garage will have parking in it. Yeah, handicap parking in it.
But is it in a convenient places for them? Uh-huh. Any EV charging station?
I do not know about the EV charging stations. I'll have to go back and look.
DT will need to know that.
Yeah, I was going to say, wonder why he's asking.
We're doing it. We don't want
No,
to-
mine's always fully
With
charged.
no cover, no.
We've already had that conversation. I asked that one. He's going to have to charge it before he comes.
We're going green, right?
The answer was no.
No, okay.
We'll have a whole car.
Can't be all things to all people, can we? David, remind me, when the garage is finished, do we then shut this garage down at that point, or is it a phased shutdown? Remind me of the transition between new garage and old garage.
I think it's gonna depend on the cup and the tower and the storage building. I mean, when we get the CMAR on board, we'll have a little bit more detailed conversation. But currently, I think we would transition to this new garage, and then we can take those down as needed. But there may be some overlap where both garages can be utilized.
We still have we still have parking available in those other temporary lots off Main Street that currently is not being utilized. We don't have the volume for that. So definitely it's a game of, a shell game of moving cars around. So, we will see those lots be utilized down the street much more as we're taking down, more fee in some of those other lots.
Have we made provision for shuttling people?
We already have shuttles in
We're doing that
place.
for employees, I know, but I mean, I know in the garage across the street, when that's shut down, when that changes, then there's going to be a lot of people that are going to need a ride to get to where they're going. And have we kind of put a plan together yet for that?
We've started to talk about it because it's actually already kind of come up in current state with some of our parking. Of course, we don't ever say no. Our patients can't get on the shuttle, but I think that probably is in our future to really understand and make sure our patients are, getting to where they need to be in a timely manner and a safe manner too.
Yeah. I think when you guys have that, where you're pretty comfortable with it, why don't we bring that back to this committee and let's just walk through it and make sure people understand what that transition looks like? Because, I mean, it's always been one of our most difficult obstacles at JPS is parking. And, I think when they design any parking lot in the world, they come to this one first and say, don't do anything like this. Completely start over. Forget the idea that this was ever built, because our parking lot's a problem. And to the extent that we can kind of begin preparing people for that, and not employees, you guys have done a great job of that, but patients and access, a lot of our people don't come to JPS but 1 or 2 times a year, if that.
Right.
So when you get in here, it is
Complicated.
it's kind of like negotiating an obstacle course.
Yeah.
So a transition plan might be a good report, just to
Yeah.
kind of get an idea of what we're in for and when we would see that happen,
Yep.
because it'll take some time to notice people on that, won't it, Ralph?
Yeah, I think that's great, yeah. Signage, all of them.
All right, any other questions for David?
I'm sorry, sir.
Yes.
Bring new technology in so that we can use, because the traffic to get out at a certain time is very hard. And if we can integrate that with the toll tag, that can speed up the process to go out. And then for those that already have toll tag, they can bill for us so that we don't have to mess around with that stuff.
Some technology, yes.
Right, a
Thank
little bit
you.
more
On the garage, yeah.
Right, just more access, make the access
Quicker.
quicker for us.
Interesting. Toll tag's an interesting idea.
But yeah, you also pay by foot before they actually
would.
get into their car.
You would have to pay for it beforehand, yeah. Interesting. Okay, so lots of questions coming on parking. Anything else for David or for Jill on the master facility plan update? All right, thank you, David. We appreciate it very much. Rory, welcome. We will start our CFO update on our financial report, please, sir.
Let's see. Well, good morning. Just a couple of comments outside of the report this morning. We do have our strategy and kind of budget retreat scheduled for July the 10th, so we look forward to having everyone available for that. We did receive word on our DISH funding in the middle of June about that. Those cuts will be rescinded, and we will have those numbers reflected in the June financials. We did not have that in the May financials. We do continue to work on finalization of the budget, and we'll present that to the Board of Managers on August the 8th. Would like to pause a moment and just thank the board members for the many contributions that you guys provide to us. Many of you have businesses and jobs and real obligations outside of here, and really we get a lot of value from your contributions, and just want to thank you for that. We don't pay in EV charging. We do pay with cookies and muffins, so the bar is open over there. So, A little bit about this financial summary for the month of June, June meeting, but the month of May. This is something that we have been working towards. In short, for the month, I'd like to give you a high-level summary. We had a very good volume month, with the exception of a couple areas, which I'll speak to in here just a moment. Net income for the month was 23 million. Our days cash was down 4 days. And then it's notable in that cash that our daily expenses are going up over the prior year. And then we do have some cash flowing into master facility plan projects. Although we do have the bond issue, we are spending some cash in that area as well. But operating cash on hand is still very healthy at 224 days. So we will dive into the statistics page, which is the other colored slide here. I want to speak a little bit about admissions. Admissions were definitely up. In particular, in this month, we are also seeing a very similar trend with tons of patients. So without that lowering of the length of stay that we've been able to enjoy over the last few months, we would be really unable to handle a lot of this extra capacity that extra patients that we're needing. So this capacity that we've created through a lower length of stay has been very beneficial. Lots of tremendous work going on, continuing to push patients through the system. Urgent care was down about 5%. I did drill into this a little bit further just to see what's going on, and it just looking at it, we had a pharyngitis outbreak last year. And we have about 200 cases less this year in urgent care. If you don't know what that is, sore throat. I had to look that one up myself. COVID, we have 80 less cases of COVID this year than last year, so that's contributing also in the urgent care. And then there's also an abnormal uterine and vaginal bleeding diagnosis that is much lower, and I think that's related to our Medicaid population that lost their coverage. So I think there's some definite reasons that we're down in urgent care. There was some talk about how we are deferring out-of-network patients from our urgent care where we do not get paid, but we're still seeing about as many out-of-network patients as we were before. So that's a little bit of kind of that urgent care status. Outpatient surgery also is the one area that's highlighted in red, and we did have a lower trend in ophthalmology cases. We've backtracked through that with UT Southwestern, one of our partners in ophthalmology, and then urology as well was a contributor to the lower surgical volume. Vascular cases are down because we are actually down at least one vascular surgeon now, and so kind of dealing with those vacancies. We did have a holiday in the month of May as well. We typically do budget for lower volumes, but that could have also contributed to a little bit of that outpatient surgery decline as well. Any questions on statistics or anything else that piques your interest?
Actually, I have a quick question for you. On admission, when it go up like that, which patient mix that goes up? I mean, a payer mix that goes up.
For
the admission? Is it, I guess, what type of payer mix that contribute to that, the admission? Is it connection? Is it self-pay or is it commercial?
It's really been steady kind of across the payer mix. It hasn't been one particular area that we've seen. We've seen about a 6% increase in commercial, and then a 2% increase in connections and self-pay. So not any one particular area is really sticking out from the admission increase.
Because I'm just trying to wrap my head around, because at the end of the day, we still a safety net hospital. And if that population goes up, then we know we're doing a good job also as well. But at the same time, it's going to hurt our financial.
Right. Yes, definitely more self-pay admissions would hurt our financials, but we're not really seeing that trend right now.
All right, thank you.
Okay. All right, we'll go quickly to the financial dashboard, which is the other new creation that we have kind of put in the financial packet. So on this particular month, we are at, there is 1 metric at threshold, 3 at target, 2 are at stretch, and then 2 are not meeting. We missed just by 1% on the cash collection goal at 99%. And enrollment, although it is still growing, it is growing at a little bit lower rate than it was earlier in the year. So we still think we'll probably hit that enrollment number, and that would be roughly 10,000 more connections patients if we were to hit that enrollment number for the month of, or for the year, excuse me.
Rory, on that, on your financial metrics, and I may be wrong, but it looks like May have been our biggest cash collection month ever, if not certainly in the last couple of years. Is there anything, is that AR effort in terms of our aging report, or is that truly just a huge increase in the number of payers that we have and the number of services we're delivering?
It really is volume driven. Our revenues and volume and throughput have just been off the charts. It's not rate driven. It's just the number of patients that we're seeing. Yeah.
That's so to the and even though you mentioned that there was a reduction in urgent care, we had a corresponding increase in emergency.
Yes.
So when you start looking at those numbers, you think, okay, you know, as we project facility planning and we're trying to hone in on those numbers to make sure that we're building the right thing for the right volume, there's still an upward trend on all of our numbers that really, I think, don't give us a lot of breathing room when it comes to building what we're supposed to build to be able to accommodate this. And I think as you guys can begin correlating, especially with your new financial metrics, which are great, and thank you for putting those together. I think the extent we can begin overlaying these financial metrics against that demand curve, knowing that we have and what's coming based on what we're seeing today, it's a good overlay to look at. Because, you know, the temptation, obviously, when you're looking at cash especially, is to try to say, okay, well, maybe we can reduce this aspect of capital planning relative to our cash position, and maybe that's what we need to do, you know, when we start talking about budget. But if you don't look at that against access and against care and volume, then you end up short. And we just keep seeing these numbers go up. And, you know, I've been on the board 15 years now, and the numbers keep going up. And it's the one thing that's common and consistent with every day I've been at JPS is the numbers just keep going up. So, you know, I salute the fact that we're doing a better job of putting our financial metrics in front of people to be able to see it. I think the second half of that is being able to apply those financial metrics to a growth curve in the future that helps us understand really what we're going to need. Because at some point, we're going to graduate beyond Blue Ribbon, right? Blue Ribbon was a long time ago. And we have. I mean, in fact, operationally, we have. But it's still sort of the policy precedent that's referred to a lot when we talk about what drove the facilities that we're contemplating right now at JPS. We're going to have to get beyond that. And I know you guys have, but I think from a policy perspective, we all need to get beyond it. And part of what helps us get beyond it is matching up this demand against the facilities and the services and capacity that we have. And you have now, I think, the financial metrics that give you the ability to measure that from an empirical standpoint. But I think what's going to be needed now is going to be that overlay against what that demand curve looks like. Because I keep thinking it's going to slowly start going down. You know, we might start to see, because there's so many other providers, there's so much more access, you know, the numbers may go down, but they just don't go down. They just don't go down. And if they keep going up, then we really got to think, okay, maybe Blue Ribbon isn't even a concept anymore. Maybe it's really something that we generate that says, here's what the new demand looks like, and kind of get past the Blue Ribbon policy altogether.
Yeah, no, I think you make a good point. I think it's, and you've brought this up several times, is we've got to understand what our capacity is. And even with the new build, kind of what is our capacity? We tend to shoot past our capacity. And we're seeing it with our ED visits and even in our inpatients. We just keep creating new care spaces depending on what that access or what's coming through our door. I'm not sure we can build as quickly as the demand is going to be with Tarrant County growing as quickly as it is. And so we really have to think of alternative ways of access. It can no longer be just brick and mortar, but access also has to include, and capacity has to include the telehealth visits, the virtual, kind of cabin in which you are, able to use an AI doctor inside. I mean, we really are going to have to use technology.
Yeah.
I think what's interesting, and I'll bring it up at the board retreat, is that within about 10 years, it's thought that there will be new entrants into healthcare, such as Amazon and others that are going to be using technology. And so,
Well, no, Mark, you've been doing it now.
yeah, so it's going to change. And so we also have to be there at the forefront
Yeah.
of change.
Well, thank you, Rory, for putting these metrics together. You've kind of finished them now to the point that I think we've got some consistency in measurement, and we appreciate that. I just, every time you read an article, I saw yesterday Baylor hadn't negotiated a new contract with Blue Cross yet. That could have an impact on us.
They're in negotiations and evidently not going as well as they wanted to.
That was right. Yeah, no, that's the problem. It's, we're
think-
still the safety net even when that happens.
I do think part of the reason you see a continual uptick too is it wasn't just unused capacity that wasn't used. Dr. Duncan and others have done a great job challenging us to create more access, and we're also going to see that next year, particularly in our clinic volumes as well. So it's a combination of pulling the right levers, but also being challenged to create more access. So.
Good, well, thank you, I appreciate it.
Roy, before you move on to the next section, on the cash collection,
Yes.
assuming it's all AR and copay deductible included in that number?
Yes.
Okay. But is the 99%, does it have any effect on the old problem we have back in February, March, where the receivables start coming in? Could that be one of the reasons why you're only 99%?
No, I mean, I think more than anything, we are seeing really from the reserve standpoint, we have become less and less conservative on the reserves. And so it's more of a timing thing from a collection. I would never really worry about 1%. From a metric. Obviously, I want to be 100%, but if you're between 99 and 102, you're probably in that range where you're collecting what your AR is valued at. So when you start to see a drop below 95%, you start to worry. But it's more timing in the AR. We do have, with the additional growth, we do have some aging out in these commercial payers. It's very much a trend now for these commercial payers to delay payment, but they're also struggling from the same growth we're seeing. They're not able to process as timely. TMHP, which is the Texas Medicaid provider, their delays are 90, 120 days now on some payments, and they used to pay within 14 days.
Actually, Medicaid, THMP is 7 days. Medicaid, 7 days.
They used to pay at 7. They're delaying so many, especially higher dollar payments now as well. So it is payer driven, but we feel like we're still in a good position from the cash collections. Trent mentioned that's the highest month. It'll be higher this month.
Wow.
Any changes in calculation of the allowable amount?
No, other than just minor tweaks in the auditors every year come in and value the accounts receivable and ask us to adjust if we're a little bit too conservative or a little bit over aggressive. But that's usually on an annual basis.
Also, that's have an oversight from the auditor on that side of it. Okay.
But they also use a balance sheet method for valuing collections. So they look at what the AR was kind of valued out on the balance sheet, and then they look at a look back to see, did we collect that? So they use a little bit different method. This is more cash to net revenue on the income statement.
But now the follow-up question is around, do we need to worry about any reserve or anything with the change healthcare hack, cyber hack? back in February?
No, we've
The reason I'm asked that question because after 4 months, they go by the letter of the law. So they just announced that to the provider that about the security hack, right? So it's 4 months for them because they're still a public company.
We had very minimal exposure in both the medical group and the hospital, so no additional reserves would be needed for anything related to change. Yeah. Okay, we'll hop over to the income statement. That's where we see the real, I would say, the increase for the month of May was really a large net revenue month. We talked about the growth that we've been seeing, the volumes, but also about a 9% increase over budget in commercial, and that is the Cigna net revenue. We continue to see Medicaid unfavorable, not supplemental, but just as a payer mix, we're down about 10.5% on Medicaid. And that is that loss of coverage issue that goes back to April. In particular, retail pharmacy this month had a very strong month. That's our specialty business that has grown in that area. And we also, we'll talk a little bit about that in the future, maybe some areas of opportunity there for specialty pharmacy going forward. And then other operating revenue is above our budget. As a reminder, Zelia and Ashley Quinones did some great work with getting some MHMR local commitment alternative bed rate increases per day. So that's contributing to net revenue as well. Supplemental there is very flat to budget this month.
Good job, Zelia. Thank you. Absolutely. Thank you, guys. That's fantastic.
Expenses are about 2.2 million unfavorable this month, but I've highlighted a couple of areas. We did have about $500,000 in pension actuary. We adjusted to our actuarial report. That was about 3.1 million overall. And then in the month of May, we also had 5 claim cycles for physician payments. So we actually paid 5 times instead of 4. And that was due to the days that fell in the calendar on our physician remuneration expenses. And then there are supply and pharmacy increases, but as you look at those numbers, they're really when adjusted for volume, we're very in line with the flex budget. And then facilities is an area that's we've been spending. If you walk the halls, please do. If no one noticed the carpet here today, you're on new carpet. Wow. So
receptive, are we?
So
thank you.
We have been doing a number of things internally and externally, refreshing the facilities. I have seen more painters than I've seen in my life. And so really landscape, if you have not looked at that, take a look when you head out of here. It looks really great. And so a lot of dollars are being spent getting ready for visitors, whoever they might be. So.
Lori, was that a one-time pension adjustment per the actuary, or is that something that we're budgeting every month to come up with out of a hole? Or tell me where we are on pension adjustment relative to the actuary.
Yeah, so we set aside an accrual every month, but when we get the actual report, sometimes there's catch up, and that was the case. We were a little under accrued on the pension. And if you think back to what's happened over the last couple of years, we've had some significant market increases in labor. That's what's driving that pension accrual. Okay. So it's essentially catching up to that additional wage that we're paying.
So, I mean, we've always maintained the goal of 100% funded on the pension, and we've always, on a monthly basis, accrued an amount. And so what you're telling me is we're going to increase that accrual as necessary as cost of labor goes up.
Yes.
To make sure we stay 100% funded, right?
Spot on.
Okay, perfect.
Yes.
is in a new facility.
It does look good.
Yeah, yeah.
It looks really good. People are doing a great job.
Yeah.
Not as a patient, but if you're just walking through
Yeah,
also.
no, it does. It looks good. Very, very nice.
Hey, we're saving a lot on contract labor relative to budget, and which I know is a thing that we talk about a lot on, I guess, just, I remember at the end of the budget cycle last year, I think we maybe increased that to have more contract labor. Anything going on there?
It's just really a better job in recruitment and hiring that has put us in a position to have more permanent employees.
That's great.
And less contract.
That's great.
We'll rebase that this year. We'll adjust and we'll project differently. But that, at the time, that's where we projected contract labor.
I mean, I think that's the story that you want coming out of that line item for
bet.
sure.
Yes.
bet.
Yeah.
All right, other questions for Rory on the income statement?
No, nothing for me, but on balance sheet, we covered the day's cash on hand. So I think if there are no other questions, we can make a motion to approve the unaudited financials.
Okay, you've heard the staff report for the monthly financial report. We need a motion to approve that. Motion from Reverend Emerson, second from Dr. Casey. If not, if all in favor say aye. Aye. All opposed, same sign. That motion carries. Thank you very much, Rory. And we will move now to Master Services Agreement between RevSpring, Inc. and Acclaim Physician Group.
Okay, so that would be mine, and RevSpring is a statement vendor that we will align with the hospital. So previously, we did not have the same statement vendor this is patient mail-out of statements. Our current adoption rate for MyChart is about 53%, but our statement, paperless statement adoption rate is about 10%. So what I'm bringing you today is a paper statement mail-out cost and contract, but we are going to create an initiative in 25 for RevCycle to just really focus on that paperless billing and kind of try to reduce some of this higher cost. Just a bulk mail postage right now is about 54 cents, so that's very expensive to mail out that. But it is expensive, but it's essential because the claim collects about 1.6 million in patient payments through this process. So it's definitely something we need to do.
Is it, Rory, does our, and I don't know the answer to this question, maybe it's a stupid question, but does our patient demographic, our patient population, our payer mix lend itself to more paperless billing, or are we kind of tied to the mail when it comes to collections relative to, just our own population?
Yeah, I think that's a good question. I would say we're probably more geared around paper.
Paper.
But I think we still don't not achieve or try to achieve that additional electronic or paperless as patients become more and more technology driven. So we definitely want to provide that opportunity.
Yeah. I mean, the more we can migrate to mobile platforms, it seems like the more likely we are to be successful in terms of getting electronic, billing done. But if it's over the PC and the laptop, I mean, it's going to have to work over the phone, right? And I know that's one of the things we've been trying to do is make sure that our platform is transformative to the mobile phone, and I'm assuming that's where we're headed for that too.
Yeah, we have, right now in the hospital, we're using a text-to-pay option, which has been very helpful. You get a link, and you click on the link, and you actually use that to pay your bill. So it's very efficient for the patient.
Good.
Does that, let me see.
I knew I was going to get a technical question. Of course. Jumped into that one.
No, because I'm trying to wrap my mind around, is that substitute for statement according to CMS? Because we send out 3, right, and then we can claim on the cost report, right, for bad debt.
It does, yes.
So it does count?
It qualifies.
But we reconcile those. Okay.
Yeah.
Just want to make sure.
And really, we have documentation within Epic around the statement date that can be produced for CMS bad debt purposes, which is what you're referring to as far as the number of attempts of collection.
Okay.
Yeah.
Thanks.
All right, any other questions for Rory on the RevSpring and the claim agreement? If not, we entertain a motion.
Move approval.
Motion from DT. Second from Dr. Fowler. Any question or discussion? All in favor say aye. All opposed, same sign. That motion carries. Thank you, Rory. You're up again, right?
Yes, sir. Forvis.
I'm sorry, one quick follow-up.
Yes.
If they have, does this have
Sorry, I already
patient,
put the gavel down, DT.
does it still have patient billing so that we can reduce the cost of stamps? I mean, a family billing type thing or multi-specialty combined to one, or they still go out by one?
Well, we do guarantor billing, which is not one by one. We actually bill at, like, if your family has 4 statements, you're going to get 1 statement for your family.
And then what about specialty, that part of our group? Do they get one by one? Or
No, they get 1 statement. If there's multiple physician specialties, they get 1.
Okay, thanks. I'm frugal, so want to make sure.
Yes, I understand. Okay, Forvis Mazars is a contract for audit, tax, and also they perform cost reporting services for us. There were 2 respondents to the RFP. One of those was Forvis, obviously. The other one was a company called Weaver. It's a larger firm in Houston. None of the big 4 firms responded to the RFP. Forvis, I would like to point out, they do have all 5 of the large publics in Texas as their auditor, and they've really created much of a niche in that area, so very much experts in that field. They are beginning their field work here on July 22nd, and then they will do their field work in October as well. So
did Forvis buy BKD? Did they absorb BKD or what?
It did.
That whole thing now is part of Forvis's. And why do you think we didn't get any responses from the other large auditing firms? As big as we are, I'm surprised at that.
I wasn't part of that RFP, so I didn't really dig deep into the respondents. But I think there's probably a way to generate interest in the future to take a look at maybe changing that option.
Okay.
More outreach.
Yeah. Make sure Daphne's cool with that.
I have a legal question on this one. Since it's under 500,000, it's a service agreement. Does it need to go to our committee, or the CEO can sign off on it?
In other words,
The total spend is over.
yeah, it's $1,079,000 over.
But not the yearly, it's total spend.
A cumulative, the contract's brought to you in a cumulative fashion, even though we don't spend more than that in 1 year.
Okay.
I'm fine with you, Ray.
I was going to say, but then you'd never see us.
We'd never have to meet.
You'd miss us.
All right, any questions for Rory on the Forvis agreement for audit services? If not, we need a motion.
Move approval.
Motion from Dr. Emerson, Reverend Emerson, second from DT. Any question or discussion? Last chance, DT.
Oh, sure.
All in favor, say aye. Aye. All opposed, same sign. That motion carries. Thank
Mr.
you,
Chair,
sir.
I'm abstaining on that.
Are you?
Yeah,
Okay,
I-
abstain.
Please,
Tim is abstaining.
thank you.
And next, Rory, is the approval exemption to bid and outside medical services agreement between Neurovatic Diagnostics and Tarrant County Hospital District. I'm sure I pronounced that totally wrong.
No, Neurovative is a company that provides electroencephalography. That is another term I had to look up, electrical activity of the brain for JPS Connections patients. We have not previously provided this service through JPS Connections. It is a unique approach. They do an outpatient testing at home. It prevents them from having to be admitted here, and so it's much better for the patient. We will absorb that into this year's budget. We are actually under budget on outside medical services, and then we'll budget for this next year. So request your approval on that service.
Does that go to MedExec? Did that? I mean, I'm curious. I mean, we've always, historically, when we add a new line of service, there is a process that we go through to add that new line of service. And many times I know it goes to medical exec, and MedExec will give us a recommendation on it. And sometimes we just do it as a cost savings measure. We've had some deep and long discussions in the board relative to new lines of service. I remember several years ago, Ralph, we had about a 3-month discussion on bariatric services, for example. What's the current protocol for looking at a new service line, and does it come to us as a recommendation of staff? Does it still go through MedExec? What's the protocol on that, Karen?
So this is actually
It's offering two connection.
It's now budgeting for.
Okay,
But
okay.
any new service line starts at the strategic level. And so following strategic plan review and then coming through the board, those new initiatives will have been vetted, performance, business plans, performance would have been completed. We would have brought them to the board before the full budget is presented. As part of that vetting, there would be your medical team that is there, along with your finance team, your strategy team, your clinical team. All of those individuals are there to ensure that we have the resources and understand what the cost of lifting that service is. So you guys would actually have view of that. There would be involvement from our medical.
Perfect, perfect. So this is a service we're providing. This just allows us to be able to do it remotely.
Yes.
Okay.
This would be something that I would classify really as standard of care.
Yeah.
Sure.
And we just haven't had a partner to work with us to provide it to our Connections
I
members.
see.
Does it require training or a clinician to do it, or they can do it themselves?
The patient, no, it requires someone to come in and set it up and monitor, and then it can go up to 72 hours, the monitoring, and then they come back and disconnect and take the equipment.
So we wouldn't consider this like IoT devices and anything like that, right?
And IoT,
Internet of Things, then you monitor offsite?
I don't know, it's not
Okay, enough.
outside monitored. I don't believe. I'd have to check on that.
Because we start putting more and more sensors, we may want to define what's IoT and what's other devices for down the road.
Okay.
It's Greek to all of us except you, right? IoT.
It's the Internet of Things. Because they trigger our security, cybersecurity, and
Yeah,
all
how
that
stuff
stuff
picked
also
up
as
and
well.
now
For down
transferred,
the
the
road, because we
data's
don't want to,
transferred.
they tap on that and change the information when they get back to us.
Good to know. So this is also an exemption to bid, so the motion needs to include the exemption to bid. So do I have a motion?
So move with the exemption to bid also as well.
A motion from DT, second from Dr. Casey. Any question or discussion? All in favor, say aye.
Aye.
All opposed, same sign. That motion did include the exemption to bid. So, Rory, now we'll move to outside medical, no, I'm sorry.
Yes.
Yeah, it's still yours though, right?
It's not outside medical, it's Intuitive Surgical.
There you go.
We use equipment in the operating room, and Intuitive is the vendor that supplies the disposables. And so it's a $2 million contract annually. I would point out that the technology really is geared around really shortening the patient's length of stay and better outcomes from an infection standpoint. And just fewer complications overall. So that's what Intuitive's equipment is doing for us.
All right, any questions for Rory? This is budgeted equipment. Need a motion? Motion from Tim, second from Reverend Emerson. Why you're a doctor today? I don't know.
You see, I didn't fight, you did it.
I should be getting used to it by now, right?
It's with the exemption to bid also as well.
With the exemption to bid. All right, we have a motion. Any question or discussion? All in favor, say aye. Aye. All opposed, same sign. That motion carries as well. Rory, you got one more?
Yes, sir. Gates Co. is a DME provider. They do provide a number of services to the patient, from wheelchairs, crutches, oxygen, everything from a DME perspective. This has been a struggle for us, honestly, for JPS to find a partner willing to help us with DME. We've gone through multiple requests, proposals, and just had very limited interest in DME for our patients. This particular gentleman that runs Gates Co. has been in this arena, if you will, with Parkland, and it's a natural fit for us, and he's willing to help us with these DME needs. But I would request, this is an exemption to bid and also approval of the contract. It's $225,000 annually.
Give us an example of DME.
Great example would be a wheelchair,
Okay.
or crutches, or oxygen tanks. It could be wound care supplies as well, ostomy care, things like that.
Why has it been difficult? I'm a little surprised.
It has really been, I think, the challenge of dealing with somewhat our population and somewhat just reimbursement rates that we're expecting to be closer to the Medicare reimbursement rate versus a higher commercial rate. Yeah.
Do they provide services like the care-centrics people? You familiar with them?
I'm not familiar with CareCentrics.
They like cost containment because let's say you have oxygen, right? And the doctor said 30 days, and they only need 2 weeks. They're going to leave it out there because it's already prescribed and take the full advantage of the 30 days. And for the patient, it's sitting around, it can cause danger also as well as it's an explosion and fire. Or the bed, they just leave it there. So care-centrics is like those kind of people, like a PBM type thing.
You bring up a great idea. There's a lot of difficulty in retrieving some of these things, especially oxygen tanks. The concentrators are a big problem because the concentrators are what create the oxygen and getting those back from the patient. So I wrote their name down. I'll definitely check into that.
They just contract, but do these people provide that kind of service for us so that they can show their performance of their outcome,
Yeah.
how they save us, right? I'm fine with the contract, but if we don't enforce that, that's the number one fraud and abuse in healthcare is the DME equipment. And we're just writing checks. So if they can have a team in place to look at those and retrieve them as patient doesn't need it, that would be great.
Yeah. CPAP, BiPAP, those things. You have a very good thought. We'll follow up on it.
Yeah, Rory, I thought we had that discussion with him, and I thought they do a lot of this retrieval.
Yeah.
In fact,
I think they do, but
it's
it's
better
helpful
than-
for
yeah,
us
than
if
we
we
could
can
do
get
it.
that.
Yeah. But I remember having that conversation with him.
Okay.
But we'll follow up with him.
Good thought, DT, thank you. We can bring that back and discuss it to the extent that it provides a benefit to us. Any other questions for Rory on this DME provider? If not, we need a motion.
So move with exemption to bid.
DT with the exception to bid, second from Dr. Fowler, is that right? Any questions or discussion? All in favor, say aye. Aye. Opposed, same sign, that motion carries. Thank you, Rory.
Thank you.
And we will now move to Austin Commercial. Construction agreement. Jill.
Yeah, this is the CMAR agreement with Austin Commercial. As a reminder, this is the pre-construction services related to the new hospital as well as the Pavilion North expansion. We awarded that contract, or the award back in April, and so this is for estimating services, constructability, those pre-construction services, $1.95 million, which is included in our master facility plan.
Does this go to Commissioner's Court?
Yes.
Okay, even this part of it, right? Okay, so after we vote on this, it'll go to Commissioner's Court for approval? Okay. Any questions for Jill? If not, we need a motion. So moved. From Tim, second. I heard a whole bunch of seconds. Dr. Fowler, any question or discussion? All in favor, say aye. Aye. All opposed, same sign. That motion carries. Thank you very much. Jill, do we have anything for executive session? Daphne?
No.
Nothing for executive session, so if there's nothing else, then we will, remind us, our July 10th is our strategic planning retreat for budget, right?
That's correct.
Hopefully everybody will be able to be at that one. We're going to get you out of here by 3, I think is worst case scenario that day. Start at 9 o'clock and we're supposed to end by 3.
Is that a directive?
That's a directive. Okay.
She didn't commit. I was watching. She wouldn't commit.
Well, let's just put it this way. At 2:30-ish, I'm headed to Amarillo. I got to be there by 8
Did I not tell you
p.m.
that Trent was going to be our?
I'm always the challenge, I know that. But you know, if you can't get it done in 6.5 hours, you shouldn't be doing it anyway, right?
Oh, I feel like he just jinxed us with that one. God. Where's Woodard? I mean, when Woodard shows up.
Here, he probably would challenge that. All right, we will see you all on the 10th. Thanks for being here today. We stand adjourned at 10:53 a.m.